So my name is Benjamin Brandt. I am a subject matter expert and consultant for the Get Paid team at PCC. That means that, I sit in on a lot of development tool meetings and things along those lines as the person that's talking with all of you to make sure that when we're developing new products in the software, when a designer or a developer is like, oh, it'd be really easy to do it this way. I say, but nobody wants to use it that way. They want to use it this other way. So talking to all of you is really important as part of my job. And then as a consultant, I do a lot of work, especially with things like reporting and things like that, to talk about workflows in the software and how to optimize certain things or pick apart report data, which is going to be a lot of what we're talking about today with pricing is how do you report on what you're getting? How do you kind of disseminate that type of material? Also, for this particular class, some of the classes got a very limited amount of time to talk about things, so it's save all your questions to the end. We've got until lunch to talk about pricing, so as I'm going through, if anybody wants to talk about certain aspects that we're discussing or has immediate questions, feel free to just raise your hand and interrupt me, because I don't think we're going to have to worry about running out of time to talk about pricing for the next hour and 45 minutes. So to start on pricing, we're kind of going to talk about the onset of how all of this works, right? Right at the very beginning, what is a CPT code? So CPTs are registered to the AMA itself. A lot of times we'll get questions within PCC that's oh, can you just load up a table of codes for us, pediatric codes for us, or can you just do this or maintain our code sets? We're in a very weird spot as a software company. Because this is all trademarked, you as offices or the pediatricians in your offices are the ones that are paying into that trademark. So when it's oh yeah, I'd be happy to show you how to go into your tables and clone a code so that you can make a modified version or add a brand new code or things like that. The reason why we might not be as enthusiastically jumping on that as we would in other aspects of the EHR is because we don't want to get into the middle of a AMA versus PCC dispute, right? So most of what we'll be talking about today are known as CPT Category 1 codes, and there are other code sets, CPT 2, HCFA, that have pricing that go into them, but the majority of your codes will be CPT Category 1 codes. Usually things like a HCFA code or something like that will be for specifically rural healthcare or things like that. They might have something that is aligned similarly to a CPT code, but uses its own code set to enter into the description. So CPT codes on their own are descriptive terms for identifying codes for reporting medical service and procedures that are performed by the physicians in a way that you can get paid for them, right? So there's the CPT codes, there's the ICD-10 diagnosis, there's also SNOMED, which are clinical descriptor terms. So you can think of those as kind of parallel, right? When you're reporting between hospital systems using SNOMED, you're doing it from a clinical basis. This is what I saw as a clinician charting, where when you're dealing with CPT or ICD-10, you're saying this is a description of the services that I've rendered that I'm trying to receive payment for. So those are kind of the splits between thinking about something from a clinical description and thinking of it from a biller's descriptor in order to receive payment. So it's made to be a uniform language, so everything is thought of the same way, so that you can say a 99213 to anyone in this room and they'll know what you're talking about, right? Because it's something that everybody does and it's a language that everybody understands. So So each CPT code corresponds to a singular procedure or service, and the intent is to transmit all possible information you can get so that they can make a determination that results in payment for that service. The thing that's unique with pediatrics is when you think about CPT as a whole, right? So this is all of medicine. So you have this subset of pediatric codes or CPTs that are pediatric specific. And when you think about, analogy that I like to make is if anybody has been in like a hospital system, right? Or knows anybody who has or has clinicians that have come from those, you'll hear a lot in pediatrics as kind of like one of the forgotten specialties, right? Where it's like, oh, we're down here and we have this. And CPTs kind of carry that thought process or weight too, where when you look at a hospital system, the most investment into making sure like the software is working correctly for them and things like that is going to be around like surgical subspecialties, and CPT is no different. Like if you look at the whole CPT book, like I think it's something like 80 to 90% of CPT codes have something to do with like surgical definitions, because they have things like, you know, oh, I did like a hip replacement and every single like screw is accounted for under a different code, where when you guys are doing codes, it's like, I did a sick visit. I'm not breaking it down to like every minuscule part I talked about. And in some cases, you're arguing with the insurances about, oh, I did these screenings, and they're like, oh, just bundle that together and just mention it here, right? Where other code sets do not do that. So that's kind of the basis that we're thinking about from the very outset. So when you determine how a CPT is made up, right? It's basically split into 3 categories. And so you'll know, so these are referred to as relative value units or RVUs. So a lot of times you'll see in PCC, you'll see like RVU styled reports or reports with RVUs. So that is talking about how like CPTs are built upon, right? And basically the way this is split is you have physician's work, you have practice expense, and you have malpractice insurance. So like anybody who has a job, right? You work the hours in your job, you're paid a certain amount, and so you're like paid per hour. Even if you're a salary employee, you still have that you know, overview of my time, or time is money. Like you always hear time is money, and it's true in whatever you're doing. Anytime you're spending working, you're getting paid for the time you're giving up to not do other things, to not be with your children, to not be, you know, home gardening, not to have hobbies outside of work. You're being paid to be there to do the work that's being done. Then there's the practice expense, right? Like, what is the overhead for you to keep the lights on? Like, you've got staff, you've got rent, you've got electricity, water, everything that feeds into your practice. So part of the expense of each of these procedures goes towards paying all of those things that you think of outside of the work. And then how risky is the thing that you are doing? So if you were to, you know, see a patient for a sick visit and something catastrophic happened to that patient and you got sued and somebody was like, it's your fault that this happened to my child, what is the likelihood of that happening, and what is the overall cost towards your practice for if you were to lose something like that? So obviously something like seeing a yearly well visit is going to have a lot less risk involved than like a major surgery, right? And while this is split up in the slide here where it's like 33% all the way across, every CPT code doesn't work that way, right? So the more risk that's involved, the heavier the malpractice percentage of that's going to be, the more intense it's going to be as a clinician to do the work, and the amount of time it's going to take into the work, that's going to increase the insurance, and then practice expense will, determine how many people are usually brought into the beginning to end section of that. And so one thing to mention as well is the people that then determine how this begins to come together into an actual pricing model is going to be the Center for Medicaid or Medicare and Medicaid Services, known as CMS. So you start with a baseline there. So we all talk about, like, especially for pediatrics, we're talking in the language of Medicaid, but it's really Medicare that's setting your baseline for this across the board. So once you have an RVU-based service, how does that deviate from like a baseline to begin to become relevant to where you are in each of your practices? Because again, part of this is the cost of keeping your business open, right? And that is going to deviate greatly based on location, because of course the United States is a giant, we're a country the size of like European unions or things like that. So practicing is going to be very different based on where you are and what kind of clinician you are and things along those lines too. So, fee for service. So this is mostly what we're dealing with is fee for service. There's also the concept of like capitation, where you have a patient list where, okay, you see 30 patients a month, and whether you see them or not, you're going to get, $5 for each of those 30 patients. And if you do see them and you do a bunch of stuff, it doesn't really matter because we're paying you monthly regardless of what's happening. But for in general, most of you are going to be basing with most of private insurance companies fee for service type schedule, where the baseline medical payment is based off of the services that you do. So each service you charge for, and then each service gets adjudicated upon, and then you receive payment from in that model. So that's going to be physicians, but also other licensed practitioners like NPs, PAs, mental health specialists. They may all have schedules that fit in there, right? And depending on where you are, that may differ as well. Like there are some states where you would have the same fee schedule as a nurse practitioner as like as an MD or DO. There are some states that will do that, but then there's others where the MDs are going to be doing most of the work, because you just from the perspective of the office, you're going to be making more money if it's the people with a higher level of education that are doing the services. So as well as that, there's going to be the geographical differences. So, if you're we've had talks this week, right, where people are like, oh, well, I'm practicing in like Manhattan, right? But then you have other people where it's like, oh, I'm in Oklahoma, I'm in Alabama, I'm in rural Texas, I'm in Dallas, Texas, instead of rural Texas. So there's going to be a geographical component to all of this as well. And the market conditions of those every year is going to be assessed, and that's going to be tied into this as well. So the business costs of your geographic location are going to be added on top of that physician work, practice expense, and malpractice to put a multiplier on here to kind of figure out where your absolute baseline should be based on where you're practicing. Because they didn't want to just set it out like, here's this giant country of America and it doesn't matter where you live, here's your baseline no matter what, right? So when you have a geographic adjustment factor, I think that's on the next slide here, conversion factor. So the conversion factors in these are known as GPCIs. So basically you take your CPT procedure with the work that's being done, you multiply it by a factor of your GPCI for your location, and that's going to give you a baseline across the board for, and again, this is a Medicare baseline. Medicaid actually tends to pay better than Medicare. So, or, well, Jan is like, no. But, or the opposite, where, so when you're setting like a percentage above what you're going to charge for a service, then you have to remember that you're setting that on like the Medicare rate too. So where does all this information come together, right? So, so we talked earlier about the Center for Medicare and Medicaid Services, or CMS, determining these things. So basically every year, CMS goes through and takes the whole CPT like book of what is trademarked, and they say, okay, so we know what all these codes are. We know what we paid for in 2024. We're going to review everything. And every year there's a yearly update where they say, okay, so for this code we're doing this, for this code we're doing this, and so forth. So that also will, you know, kind of spiral out, because that is information you can get, right? Like there's places on CMS's websites where you can find all of these in very like esoteric spreadsheets that you download and go all over the place. And so of course, there's not only going to be places like PCC that are going to be like, let me scrape all this data out for pediatricians. There's also going to be actuaries at insurance companies, middlemen, things like that are like, okay, so how can we best adjust our fee schedules when they come out and we sign new contracts with somebody in, you know, Alaska to maximize what we're going to make as a for-company profit, right? So basically there's going to be that push and that pull between us and them, right? Where we always say at PCC in the Get Paid team, we're trying to maximize the money that you're making, right? And so they're doing the same thing. They're trying to maximize the money they're making, so they're trying to find ways to claw back things from you, while we're trying to find ways to claw things based on what CMS says to you know, get you a couple more pennies here and there so that you can make up the difference, right? So once this has all been determined, this is usually out right around the end of the year. Then, like I said, PCC will go through and we'll grab all the pediatric data, right, for all of these CPT codes, and we'll load it into the system, kind of like in the background without you having to see anything, so that when you run RVU reports, the relative value unit reports, you can set a year, right, of this is for year here, for zip code here, in a way that, you know, it both determines, you know, this year's CMS as well as your location to figure out the GPCI multiplier, right? So RVU-based pricing in PCC. We'll get back to the report section of this, but what we're gonna actually start with when we think about how this all works within PCC system is we're gonna actually start on the dashboard. Because one of the things that's really nice about the dashboard is everything is visualized, right? You see a lot of different styles of graphs, you see a lot of information, and especially for something like pricing, where the baseline for this is going to be something you set yearly. It doesn't matter if the dashboard updates every day or every month, because in this case, and for those who are not, you know, dashboard aficionados, then our dashboard does update once a month. So there's like a freshness date that you'll see in the dashboard saying last updated as of this date. But once you get into the new year, so if we're thinking in terms of 2025 right now, and you're thinking about doing something for pricing in 2026, once you get an update for 2026 and you look into the actual pricing models, then you will already see at the bottom of that, you will see things for 2026. In terms of, for what I prepared today, I cut it off at 2024 so that we could pretend this was the beginning of 2025. But once you get into your pricing, you'll see how you're currently doing with pricing compared to other practices. Again, that's going to be gauged against other PCC practices. And one of the things that I always like to point out with this is that independent pediatric practices that go with PCC tend to be very clinically and financially minded, right? Like nobody's going to pay a giant amount of money for PCC and not just go with some fly-by-night web-based EMR solution if they don't care about how their results are, right? So you already have kind of this echelon of people. And so when you see things in here where it's oh, I'm in the top 10, or I'm not in the top 10%, you're talking about, I'm not in the top 10% of PCC. So I'm not in the top 10% of already the top 10% of peds and even independent peds, which is probably also in the top, 30% of all peds when you take in the hospitals and everything else and the lack of attention or care they give to your profession, right? So I always say, don't beat yourself up if you see a pricing model and it's oh yeah, I'm in rural native country and my pricing isn't as high as, my friend who's in Manhattan or my friend that's in Atlanta or things like that. There's some things like this, especially pricing, where it's I can do the best I can do for my practice, but I can't just compare myself to everybody else on a blank slate. Because again, even though we're adjusting for geographic location in your individual pricing, that isn't suddenly going to be reflected and show my pricing is as high as people where the pricing is higher, right? So when you go into the dashboard, then when you go into the financial oversight section and you go down to the pricing section, you click on that, there's a little related tools for each of the dashboard reports. There's a hyperlink in there that will bring you to your annual, state, regional, and national benchmarks. So this is really, really kind of vital information for you, right? Because what this is showing is based on, again, what CMS has said and what we're adjusting for GPCIs, for the geographical modifiers. Then you're going to see nationally what prices are. You're going to see what prices are if you were to average those out across your entire state. And then you're going to see right for your region of the state, what those modifiers would do to you. So in here, I know this is a little blurry because of the projector, but if you look on here, you'll have a practice average, state average, regional average, national average. And each of these percentages, you'll notice each and every one of these percentages will be at 100+%. And that again is because this is your average charge, not what you're being paid, but average that you're charging that's multiplied against just the base flat Medicare rate. So you're never going to charge 100% of Medicare across the board because you'll be losing money hand over fist and you'll be closed in a year, right? Because it's if you were charging, because one of the most important things to consider when you're thinking about pricing, right, is there's not an insurance company in this country that's going to go out of their way and from the goodness of their heart say, oh, you only charged me $50, but I would have paid you $300 for this. Let me just give you another $250, right? No, they're gonna say, oh, you asked for 50, here's 50, I'm moving on with my day, right? So when you look at percentages and you're over 100%, you're like, yeah, good. I want to be over 100. I want to be over, I want to be over 150. I want to be over 200, depending on where you are. You want to be at a percentage where you're always going to be charging more than what you're going to be paid. Because if you're not, you're just losing money right off the bat, right? And even if you don't have a buffer above that, then if anything changes on your contracts throughout the year, they're not going to tell you. Like if you have a provider across town that's been, hounding Blue Cross Blue Shield for the last 6 years about how you should get paid for a specific screening, right? And so they cave and, they put a new policy in place for the contracts that now, for that area, they've made the case where it's going to make the insurance more money because now that that's being screened, there's going to be less services that need to be done in the future that would be more expensive for insurance to cover. They just blanket raise it, like nationally or regionally or locally or whatever. They're not going to go out to each individual pediatric practice and be like, oh, hey, by the way, we're like reimbursing you an extra $1.77 for this screening. No, they're just gonna start paying that more, right? So if you try and get you could go through and get everything to like the penny, right? Where it's like, oh, my very best payer pays me $236 on this service, so I'm gonna charge $237. And then I have less write-offs to do, right? But then, that occurs, you get an extra $1.70, and now you're losing 70 cents, right? That you could have. And realistically, as far as like I'm concerned and PCC is concerned, like in this position, every cent matters, right? Because we're not talking about the difference between like a $15,000 hip surgery and a $14,000 hip surgery. We're talking about the difference between getting paid, $15 for an admin code and $16 for an admin code, and those differences really do matter. So when you see these numbers, you're going to want to look at those percentages, and you're going to want to determine like how you've been doing in the past, as well as what direction you want to be moving in for the future. And a lot of people feel like really kind of torn on that, right? Because it's like, oh, I feel like I'm charging so much because I'm like this many percentage points above what the absolute like garbage minimum could possibly be. And one of the things that I would always say to combat that is think about things like the hospital systems, right? Think about when you get an EOB because you've gone in for an adult care and you get something back from your insurance, and it's like, oh, this would have been, $70,000, but the insurance paid, $260 and wrote off $68,000, and your deductible or whatever is $150 or have something like that. And the reason for that is because, hospital systems are so large compared to where you just have this hyper-focused department where they're not going to look at this every year, right? They're not going to do what we're doing to adjust their pricing appropriately to make it make sense. They're going to go in there and they're going to say, okay, this is what CMS says. I'm going to do 3,000% above that because if I don't check this for the next 15 years, it's not going to matter. They're never going to pay me more than I'm charging because like inflation rates in this country are not going to hit a point where even when you deal with like the 2008 crisis or COVID or things like that, where there's these like giant chances of major inflationary events, it's never going to be year over year percentages high enough to get above like the 3,000% over what they were charging or what they were paying in 2007 for me to worry about it, right? So when we're looking at this and saying, okay, we're doing like, 150% over or 250% over, that's still going to be way lower than like any hospital, right? So usually what I recommend on here is you look at what your practice average is. And the first thing you want to look on here is what your regional average is and then what your state average is, right? And you want to compare those and you want to see, and ideally you want to see your percentage for your practice to be the highest of those three numbers, right? Because if you're lower than your regional average already, that means other people in your area are already charging more than you, right? And even at like a state level, for the most part, you know, depending on where you live, obviously, possibly for something like California or New York or Georgia or something like that, maybe there's a little more leeway where you're like, state isn't really like vital to this. But if you're in like Kansas, Oklahoma, Alabama, Louisiana, like some places where 90% of the state is going to be similar, or even, you know, like Vermont. We've got Burlington as our like big city. You've been here, this isn't a city, right? like you're like, but yeah, yes, for my mother, this is a city. For my mother coming from central Vermont, where she gets off onto the highway right next to this hotel, and she sees, you know, a circle loop to get off the highway, and then there's, you know, 3 stoplights in a row, that is considered the worst traffic she's ever seen in her life, and she is convinced someone is going to smash into her and kill her because there's people driving 35 miles an hour past the lights, right? But for any, so you take that into consideration. There's plenty of states that are like that. Like if I was looking at Vermont, I'd be like, yeah, throw state in there as well if it's higher than my regional, because if I'm in, you know, if I'm in the, you know, Johnson, Vermont area, or Stowe or Killington or something like that, like those are expensive places to live. They're probably more expensive. Stowe and Killington are probably more expensive than Burlington overall, but but that's probably not going to be reflected in here the same way. So you can make judgment calls on that. The overall point though is you want to make sure your practice, your percentage is the highest of the ones that you're looking at that you find relevant, right? Like if your practice average is 140% and the regional average is 145, you should consider going up to at least 145, maybe 150, somewhere in there, so that you're competitive, right? And let me see what we've got for, but other than competitive, you also want to be consistent. You want to have that baseline so you have a consistency across the board, so you know like, oh, at the lowest possible level, I'm consistently charging things based on what CMS has said, right? Based on everything, I'm moving all of my prices up to a baseline that fits with, I should get more for this service, I should get more for this service, I should get more for this service, or less, or however that fits in. So how does this fit in once you actually want to report out on it? Because now you've determined what your percentage should be. And now we can talk back about where I mentioned we had RVU multipliers and regional multipliers, right? So, was there? Okay, must have been an echo. I thought somebody else was asking something. So, typically what you would do is you would find the RVU report that works best for you. I'm going to be talking today about the things that work best for me. If you have a report that you already run and it works for you and you like it, that's fine. So what I like to do is go into practice management, go into the Smart Report Suite, because all of those reports are ones that you can export out to a spreadsheet, right? That's why it was originally named the Smart Report Suite. We have, you know, an antiquated enough product that there were times where reports could only come out as like text, right? You'd run a report and you print it out to your, you know, Oki data printer on dot matrix paper. So this was called the Smart Report Suite originally because this was the first time you could take a report and send it to yourself in a file that you could open in Excel or put into a PDF and have it look pretty, right? So when you go into the Smart Report Suite, there's actually a suite of reports called RVU reports. And in there, the one that I recommend using, the one that I like the best, is called reimbursement analysis with RVUs by CPT code. And the reason I like by CPT code is what it does is it takes each of your CPT codes. So say you were doing office visits, you'd have 99213, 99213-25, 99213-25-59, 99214, et cetera, et cetera. And instead of just having a single row for that one code, it will have that code, and then sub-sorted under that code, it will have private, no insurance, Blue Cross Blue Shield, Molina, Aetna, Cigna, whatever all of your insurance categories are, so that as you go across and you begin working on pricing, you can actually not just break it down by, we saw 300 99213s this year. You can say, we saw 100 Blue Crosses, and we saw 50 Molinas, and we saw 16 privates, and so on. And so you can actually see what you charged out for all of those, what you got paid out for all of those as you're working through increasing your pricing, right? And so when you go in here, typically what I recommend is when you do this at the start of the year, try and do this, somewhere between like January and April, right? Because again, it's January. A lot of times you're going to be full of things like, oh, everybody's updating their financial policy, and I have to go through all of these because I wear 18 hats in the practice, right? But find a time near the start of the year to set aside like one of your weeks where you're going to work on pricing, right? And when you do this, my biggest rule of thumb is to remove the last 3 months of data from your report, right? And the reason for that is it's usually safe to assume, and you will know this on a practice level, this is a generalization. On a practice level, you might be heavily Medicaid and know that you have certain payers that don't pay that within 6 months. So maybe you run this twice. You run it at 3 months to get all of the private insurances, and you run a second time at 6 months of data removed just to look at the Medicaid line to see those, because those are going to be slightly different. But as a general rule, you can say, I'm confident that if I looked back 3 months, I'd be somewhere between like 96 and 100% of payments for all of the payments that were due. I'll have one or two little ones that don't match up that I'm fighting over, but for the most part, my payments will come in and have been worked and rectified by that point. Even if I didn't get paid, I would have, put an appeal through by now, and it should have come back, right? So if I was, say, doing, 2025 pricing, and I was looking back at 2024, I was doing this in January, I'd look back and I'd get rid of December, October, September, November. I'd get rid of November and September. I think I got that right. October, is that right? Okay, so I'd get rid of those 3 months. And then for my database year, I'd use this year, right? I'd put in database year 2025, and I'd put in my multiplier based on what we just discussed on the last page, right? I'd be like, oh, last year, practice year, I was at like 136%, and I looked, and actually I should bump this all the way up to 155%. So I'm gonna go to where it says RV multiplier, I'm gonna change that to my 155, and I'm gonna leave my zip code in there. And so what this is going to do is it's going to give you basically 2 sections of information put into a single report, right? It's going to have your true data from your system, where it's got all of your charges, all of your visits, all of your payments, right? But it's also going to have a section where you have your RVU multipliers, which regardless of the date range you use, is going to be determined by that database year multiplier and zip code, right? Because that's going to find what CMS is reporting on. It's going to then multiply it by your zip code to get your actual RVU, right? And then it's going to take that final baseline price and it's going to multiply that by the multiplier that you've selected to say, if I was charging this at, 140% above Medicare, this is what my charge amount would be. Everybody with me so far? Okay, cool. So, wish we had a really high definition screen. Yeah, unfortunately. Although anybody who has their computer out, if you're following along in your slide deck, it's much clearer on there. But so basically, this is what I said here, right? Like, so I ran this only for, or at least for the example, I ran this only for well visits, right? Just to get some example data. But here I have, PE under 1 year. I have the 96361. Is that right? 391. Thank you, Linda. And then I have my different insurances. Units accounts for number of visits, right? And then over here, what we'll be talking about first is the RVU Medicare FAFC at percentage. So that's at your 140%, 250%, 370%, whatever you're multiplying it by. So the first thing we want to do at the start of the year, again, is create a baseline. We want a baseline for everything in your system so that you can establish a pattern as the year goes on, right? So the easiest way to do this without doing any extra work, right, is, and I believe that is on my next slide. Yep. Oh, good. This is a little bit clearer. Okay. So what I did here is once you're in any type of spreadsheet program, whether it's like Excel or LibreOffice or like a free to use software, a Microsoft 360 one, I think it's like Numbers in Macintosh programs. There's things called functions that you can put in to like determine something that goes on throughout the entire spreadsheet, right? So in here, I did a very, very simple function. So to start the function, I put in an equal sign in a new column that didn't have any information in it. And then what I did is I looked at where my information started. So my information in here started on row 4. And the information I actually care about are in column H and column L. So again, we're setting a baseline. So column H is, this is my charge. This is my average charge. And so what that means by average charge is you have this amount of units. So you take your total charges that all add up, divide it by your amount of units, and that gives you your average charge. And one thing to remember about that is it's not always going to be 100% consistent as you go down through, which is why I like to split this out into individual payers, right? Because maybe you talked to insurance last year in June, and they're like, oh, like we have a new contract, you need to bump up your price, but because you ran this for all of the year, maybe in terms of these 240 here, yeah, so this is a great example. So this had 8 visits, it was 240 and 0 cents, 240 and 0 cents. This one with 240 visits came out to an average of 239 and 83 cents, which doesn't seem like a big deal, right? It's like, 17 cents or whatever difference. It just means that out of those 240, one of those was probably like marked as 0 or something like that. So it brought the average down by 17 cents, which is why I like to have these broken down, because if you have something that's like a strange outlier in here, you're going to want to see that in your last column, because again, this is to determine if you need to even do anything, right? So So when you have your average charges, right, that's in this particular, and again, this is the spreadsheet that I like to use. If you use a different RVU spreadsheet, it might have different columns. So it's important that you're just looking for the average charge amount column when you're doing this. But in this case, that's column H. And then I have column L, which is if I was to take what Medicare pays, multiply it by my multipliers that had already been figured out, it would be this much money, right? So I do an equal sign to start the equation over here in column O, and I take my charge amount in column H, and I subtract my what I would be charging on Medicare in column L, and that's my full function. From there, I hit enter, and it will either be a positive number or a negative number, right? If it's a positive number, that means you're already charging more than what this percentage would be. And so when you look at the dashboard next year, your percentage will be higher than the percentage you used, right? Or it will contribute to that number being higher. If it's a negative number, it means that you need to raise this price, right? So once you have a function in like this, then I'll try and explain this without an actual spreadsheet. But usually you'll see, like if you click on that column, there'll be, or that cell rather, just the cell in that column, there'll be a little box in the left-hand corner that's sticking out of there. If you put your mouse over that and click it and start dragging, you can drag that same function down through every row on your spreadsheet. And what it'll actually do is, again, so this was row 4, right? So this row 4 would be, you know, H4, so H and 4 minus L and 4. So when you drag it down, the spreadsheet is smart enough to say, okay, so this is going to be H5 minus L5, H6 minus L6, etc. as you go down. So instead of you having to like try and eye the spreadsheet or figure anything out that way, you just drag this all the way down. Then you come over to this last column and you can either sort by that from like lowest to highest, so all the negatives go up to the top. That could make it really messy. You could also, you know, just like go through and eyeball it and like highlight them. And then what you'll do is you'll find, okay, so out of my, you know, 880 procedures, right? I have 70 procedures I need to update, right? So I went through and out of all of this, I've never done my pricing before. I have 70 things that I need to increase the pricing on. So what you do is you'd have those codes, right? And then you just go into your procedure table. You'd look at the codes that were negative. You'd look at what the price would be here, and you know, you eyeball what would be the most appropriate, right? Like if it's $240.83, maybe you put it to $241, maybe you put it to $245, like whatever it's going to be, so that it makes sense to you, right? So that it's like, oh, like this is a nice round number that makes sense, that would, you know, look appropriate on a sheet, right? Because again, like on here, the average charge amount that we started with was $240. That's a nice even number. Over here, it's $240.51. So it's like, do I even care about that 51 cents? If you're me, yes. but you know, then I determine, am I going to just go up to 241? Am I going to go up to 245 because it's, again, a nice round number? How am I going to do that? Okay. So any questions on like the functions or any of that? Yes.
Okay, well this is more of a philosophical question. I think I know what your answer is going to be, but I'm going to ask it anyway. So this is a lot of work, and you know, we're doing this yearly at least.
Yep.
But the hospital, who has all the resources,
Yep.
is going to do 3,000
Yep.
once every 15 years.
Yep.
Why? Like, what's the downside to saying I'm going to do what the hospital does? I think I know the answer. But
So the downside of doing what the hospital does is you have a lot of caring physicians that are going to deal with, you know, like, I live in a border town. I've got a high immigrant population. I have, you know, we're by the mine, and a bunch of people like lost their jobs and lost their insurance. So I don't want to sticker shock someone into being like, oh, this office charges, $3,000 for a well visit. And then even if you're like, oh, I'll give you a discount and it'll come out to be like, $80 or whatever, it's like in their head, they're still seeing that $8,000 price tag.
And we have to do the discount ahead, right, legally,
Yes.
for cash?
Yeah, and I'll get that into,
Okay.
it's fine. No, it's a good question. It's a great leading question because that might actually even be my next slide. Yes, so that's mentioned in my next slide. But yes, you always, you never take the charge and say, I'm going to charge insurances this amount of money, but I'm going to charge patients this amount of money. You give them a discount so that you're charging the same across the board, because contractually, insurance companies have all the power, right? Think about all the things that you can't do that the insurance can rip your guts out with. You have to charge us all the same exact amount of money. You're not allowed to talk to you even that because you're in the same town, because now you're price fixing against the insurance companies, right? Because we live in a competitive society where the free market is going to lower the price of things because efficient companies are going to try, and it's like, no, that's not how any of this works. They're going to find out who is doing the least and do just above that, right? Because they can all find each other's data and things like that. Yep, Linda?
So when we do all this work, which is great,
Yeah.
I mean, definitely have to do it. Why can PCC not bill them at 250% fee versus us having to do it individually on each code? Or can you?
Okay, so that relates back to when we go all the way back to the beginning of my talk, where it's technically PCC is not allowed to be involved in your CPT procedure codes because they're trademarked by the AMA.
I don't want you to touch the code, I want you to touch my prices.
Yeah, that's what I mean. Touching your prices is touching your code. but yeah, that is the honest answer to that. Is we as a company need to be really careful with that. If we look at it from the terms of, okay, so we're PCC, right? We're kind of troublemakers. I think everyone here could say we rouse a little rabble. So there's things like the RVU price calculator, which Chip has put on his blog, which him and Polly talk about with PMI. We've had legal threats from the AMA about its existence, even though it doesn't have a single CPT code in it, because the function of it is for you to input CPT codes and get an output. So we need to be legally, we need to be, as a company, really careful about their trademarks. Yeah, go ahead.
American Medical Association, why are
Yep.
they not supporting, why are they trying to make things harder for us?
Right.
I mean, granted, I put Pando's dues,
Yeah, I was gonna say write them an angry letter. I'd be perfectly happy with this. And yeah, again, we have plenty of time, so we can break this down into a whole discussion about being mad at the AMA. But yes, it's I believe that there's fees involved in you having it, similar to coders having to pay for Red Book and things like that, and PCC including that and things.
I would pay them for this almost feels more like this is like a backdoor way for insurances to control us better through the AMA. Sorry, that may.
Yeah. No, it's fine. Well, I think in this case the anger is directed incorrectly, because I don't think it's backdoor for insurances. I think it's that we live in a capitalist society, so if there's money to be made on something, then especially when you're talking about intellectual property law, people are going to have their IP trademarked in ways that they can maximize what they're getting from it. And so I'm not going to make a moral judgment about why the AMA does that and what they do with the money and things like that, but that's really where that breaks down to, right? But that is a good question, Linda, is why don't we do it?
If we're doing the work, and I don't want to sound disrespectful,
No, 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 absolutely.
the bomb. But if we pay for your services to support us and we do your work, do the work and say, we want you to increase our CPT codes by this amount, and, I mean, we're asking you to do it, you're not out randomly doing it on your own, how does that not cover you?
Yeah, I think that's why we set it up the way we did with it being reports, because I think that was as far as we could push the envelope in terms of like, okay, so we already scraped CMS for all the CMS data, and we already scraped GCPI for all of the multipliers, and we put in a multiplier section 4 here so that that could go into the report. I think that's as far as like we could push the envelope to get to there. And I think what you're saying is valuable in that as a practice, and this is a philosophical part of this, as a practice, if this is something that you're putting the time and effort into, the important thing to think about is that as you put your pricing in, right, then each subsequent year when you do that, when you run a report like this out, you're gonna have less and less codes that you have to do. So this should be like, one thing that I want people to come out of this with is if you do the upkeep for this, right, then every year that you do it, it's gonna get easier and easier. Because every year you do it, you're already going to have adjusted up codes. And there's a whole other section we're gonna talk about in terms of like charge versus payment amount, right? Because we talked about that near the beginning and putting that in there. And there are, to speak to what you said, when we talk about what's on this slide, there are some things like self-pay, where we can't, because self-pay removes all of this out of it. So there is a way with self-pay to, because what most practices will do, and again, I'm kind of spoiling well, yeah, not even this slide, there's a further slide to talk about this, and we'll talk about it again there. But a lot of practices will have their own fees for services, for discounts, where they'll say, oh, we want to charge this exact amount, so no matter how much you raise the charge, they're always paying the same exact amount. And that's a lot of upkeep, right? That's a lot of upkeep to put all those in for yourself, to do a secondary schedule for those. But there is also the ability, and I don't know if this is a lot of people don't know or a lot of people choose not to use it, but in that you can also just tell PCC, oh, I want to set our self-pay discount across the board to 20%, 25%, whatever you want there. And that one we can just go into your configuration files and say, okay, we'll set it this way and it'll discount everything, which means when you raise your charges, then what they're paying also goes up an equivalent amount with the same amount of discount. But at the same time, if you notice your charge going up a lot a certain year, you could be like, oh, we were giving a 20% discount, now we'll give a 25% discount or something like that. So we will talk about that near the end as well. This slide specifically is just mentioning kind of that fear, right? You have a fear of overcharging your patients and like getting bad word of mouth about your practice. So I'll actually start with the bottom of the slide rather than the top. But that's a factor, right? Self-pay patients who pay at time of service, they normally receive a discount. So we can help you set up that discount to happen automatically based either on what you've decided as a price or by a percentage discount. But there's also gonna be that sticker shock, right? Because a lot of times, or not a lot of times, I think it's actually required that if someone comes in and they're going to be paying out of pocket, that you represent to them like kind of a pricing sheet to say, if you come in for a well visit with or without vaccines, it's gonna be around this much money, right? Like you have to let them know like beforehand, this is what the price could be. Good faith estimate, thank you, yep. So if you're making good faith estimates and you're showing your true charges with those, then they might be looking at the charge part and not the payment part and be like, wow, this is a really expensive office, right? So that again fits into that, why wouldn't I just raise things up to 3,000%, is it just takes, everybody knows how like Facebook and Front Porch Forum and everything, like social media, it's like one negative comment can spiral, and then all of a sudden you're known as the office that nickels and dimes them, or yes, it would, but we're talking about humans here. That some people will look for the most negative thing they can possibly find in a situation, right? Something else to talk about that's even more pressing though is going to be things that don't come out with any kind of price when you run this, right? Because the CMS is only doing this based on services that they pay for in that way. But there are also other services. Of course, the most obvious one is going to be vaccines, right? Where it's like, we state supply vaccines to the states. So our price is going to show 0. So no matter what you multiply with, this is always going to remain 0, right? So you need to, after you run out the spreadsheet, I don't know what we can call it, the spreadsheet, magical spreadsheet, whatever you want to, however you want to frame it. When you've done the work on the spreadsheet, you also have to look at those things that were zeros. And again, that should be obvious on there. You should be able to sort it by the zeros if you want to see those. But you want to determine, is there anything that CMS cannot give us the information for that we have to find out in a different way, right? And so specifically for vaccines, just because that's kind of the big one, I just wanted to separate that out into kind of its own thing. You got to think about it in terms of, okay, so what are we dealing with specifically for vaccines, right? So vaccines have costs and payments that are involved with them. So you have the cost of the vaccine itself, what you're paying to actually buy the stock of the shots that you're giving. You purchased a fridge, you're powering the fridge, you're using space in that fridge so that if you get to a certain point, you might need a second fridge, and then you're paying for more storage and more power and things like that. So in terms of like, especially for an office that has not been in operation for years, right? You're a brand new practice, or you're splitting off from the practice that you've been with and you're going out on your own. There's no bigger upfront cost than your vaccines, right? Because you got to buy a fridge because you don't have one. You got to buy all of your initial stock and you're not making any money from it yet, right? So you need to figure out those two factors, right? Like, what am I paying for my fridge? What am I paying for my stock? But then you're also getting incentivized in some way, right? Like, not only are you being paid by the insurance for the vaccine itself, but you're getting paid for admins, and you have to kind of look at it, how do I do my admins, right? Like, am I an office where we're so busy and the MDs don't have like time to be in there explaining all of the vaccines and why they should have them and things like that, and so we just do immunization only visits for everyone, and the nurses do it, and it's just like in and out, like as if they had gone at a CVS. You're not going to be paid the same as if you're able to go in as a pediatrician and talk to them through things, right? Because the biggest difference is going to be things like MMRs and things like that, right? Where you have a 90460 and then you have multiple 90461s versus the 90471. Thank you, Jan, my lovely, wonderful coder who knows all the codes back and forward. I was like, you saw me looking right back at you being like, will I get it right the first time? So that's something to consider as well, right? Like, so when you're looking at, again, like something like an MMR, it's like, I'm getting paid for this, I'm subtracting out the price of what it was, the price of what storing it was, but also, like if I look at just that data and I'm like, oh, I'm losing, $10 every time I give one of these vaccines. If you then, also figure in the fact that you as a provider are doing this and you have a 460 and the additional 461s, and for those I get, $15 for this and $5 for each additional one, or whatever your price structure is, you might find, oh, actually I'm making a $25 profit, so like, you know, obviously you want to make profit wherever you can, but as long as you're at least like breaking even, it's like, okay, I'm good there. And for billers for billers that are figuring out all of this, you may also need to, you know, involve other staff too, right? Because one of the things that I always talk about in terms of like what is considered money within a practice, right? Like a lot of people are like, oh yeah, like every time someone touches a dollar bill, like they need to report out on it. And then you talk to them about their nurses and it's like, so how often do you have like the nurses go through and like reconcile the vaccine fridge? And people are like, what? And I'm like, that's money. Like every one of those bottles is like a roll of bills. Like if you're going to reconcile like every cent somebody has taken in for their drawer today, you need to, and you're that serious about it, you need to reconcile all of those things that are in the fridge too, because if somebody wastes a dose or misses a dose or something's missing, then, you know, that's money you're losing right there, right? This does not have to do with pricing, so I've gotten off track, but I just wanted to, you know, get on my soapbox for a second. So yes, so back to pricing where it's zero from the CMS, especially for vaccines, you're going to want to like think through what I just talked about with vaccines for anything that might not be paid for CMS. Like, what is my cost for this? What is my payment for this? And how do I make this make sense so that it pays? And again, if you're doing this every year, you might not have to review that, like something like vaccines every year, because what you will be able to see is you'll be able to see on this report, you know, you'll be able to see what you're making for your admin codes, and that will tie into what we're talking about, I believe, next. Yes, so adjustment for true reimbursement. So far, what we've talked about is a baseline, right? We've talked about how do I set my baseline prices across the board so that I know I'm charging what I would have at my lowest amount. And then there's true reimbursement. So true reimbursement is I charged this amount and the insurance actually paid me this amount, right? So the reason I like to break these down into two different things is I find it's a lot easier to work reimbursements if you've already set your base prices at a level where it should be above where your reimbursements anyway. So again, the more like upfront work you do, the less work you have on the back end. So again, when I talked about things earlier, I like to cut 3 months of data out of this. So my personal recommendations, this is not PCC sponsored, this is Ben Says, is do pricing twice a year. So at the beginning of the year, you do your baseline pricing, right? So we do everything that we've talked about up to this point. Then give it 6 months for your baseline pricing to set things in motion. And then, you know, halfway through the year, and when I say halfway through the year, if 6 months later is like right in the middle of well visit season, push it out a little bit. Like don't be so staunchly in like, Ben said this, so I'm putting it in a stone pallet. Find a space around 6 months later where things are going to be a little less crazy at your practice. I know they're always going to be crazy, but sometimes it's more crazy than others. And then look at how you've been reimbursed up to this point, right? So when you do that, if you have a good 6 months, you're going to, again, cut out 3 months because you still might be getting paid for what's happened in the last 3 months, but you'll still have a good 3 months of data, which should at least be enough that you have some charges on most of the major procedures you use, and most of the major insurances have had like at least 1 or 2, right? So you cut out that 3 months, you run this report the same exact way that you did before, and what you're looking for here is, and This is more of a PCC recommendation, because I know I recommend this, Chip recommends this, Alex recommends this, at least a 20% buffer between what you charge and what you're paid. And again, that fits back into what I was talking about earlier, where things can change throughout the year, so you want things to go in there. And we also talked about how there's units, and you're finding the average of the units. So when we were looking at charges, we had that one where it was like 17 cents less. So extrapolate that into, if you extrapolate that into payments, or what I say, leaving space to breathe, right? Is if you're like, Linda said, this is a lot of work, right? Just even what we're talking about now is a lot of work. It could be so much more if you wanted it to be. I don't recommend for it to be this much work. But you can actually go into report like charge-based reports and say, I don't want to see 240 units. I want to see 240 line items that shows me this patient, this patient, this patient, this patient. And I want to see every place where I got paid and I had adjustments. So I ran this to show this report here. So this is the same $240 charge, right? And same exact insurance, same exact copay. One paid $179.57, one paid $99.28, one wrote off $60.43, and one wrote off $140.72, right? So that also makes up that 20% buffer, right? Is if you have these idiosyncrasies where they just randomly decide to pay you a different amount, since you're only looking at averages, that will fit it in there. So if your average is say $180 and there's like 6 of these that are 0, and that brings your together average down to 160 or whatever, you might think, oh, I'm charging enough money if I'm at like 165, when in reality you're not, you don't have a big enough buffer, right? So again, going back to Linda, I'm not picking on you, Linda. I'm saying this as a good thing. You don't have the time to spend all day on micromanaging all of these things. So if you can get something that works for you as like a percentage, rather than looking at each individual charge, it'll save you a bunch of time, right? Okay, so again, I ran out the same exact spreadsheet we talked about before. And so the only difference between this and when we did this 6 months ago is going to be the formula that we use to figure out what needs to be changed. And so now, instead of doing a subtraction, we're not even looking at the Medicaid RVUs anymore. We're looking at true numbers, the average amount that you charged and the average amount that you deposited. Those are the only things you care about in this case. So what I did again is, I did an equal sign to start a function over here, and I took the average charge amount and I divided it by the average deposit amount. And so you're looking for a quotient of below 0.80%, right? Because if it's at 0.80, that means your payments that you're getting in are, on average, are 80% of your charge, which gives you a 20% buffer, right? And so if it's 0.079 or lower, you ignore it. If you see any, and again, this is where having the different insurances comes in really handy, because obviously every insurance pays you differently. So all of these percentages, unlike the charge we had on the first one, can vary widely, right? And so on here, you just go through and you see if anything is above that. I think I had one on here that was like 82%. So I would take this procedure code and I would raise the price. And if not, I would leave it alone. And the advantage of doing the two of these in tandem with each other is the first time when you're setting the baseline, right? Your baseline sets all of your prices, and so if things don't change next year, you don't have to change anything at all, right, on there. And then true and reimbursement can do nothing but raise prices, right? Because if something is, if something is at like 65%, who cares? The price is already like built in, and it's done so in a way that makes sense with the rest of your things. Because you're just using math to say like, this as a baseline fits in with everything that I have. I'm doing it at a baseline amount and everything is set. And so what happens is, because you're doing the both of these, and again, it's like, if you've ever seen like those perpetual machines where, or even like a slinky, right? Where it's like, when you take a slinky and you do like the first stair, it's kind of like, and then as it goes down the stairs, each subsequent stairs, it's just powering itself by then, just like chunk, 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 chunk. And so these are gonna work the same way, where the first time you set a baseline, you're gonna have more codes to do. The first time you do true reimbursement, you're gonna have more codes to do. And then each subsequent year, you'll run this out and you'll look through and you'll be like, oh, I got like 5 codes this year, I got 6 codes this year. Like, I run the report out, Ben showed me the function, or like literally call PCC and be like, what do I put into my spreadsheet to find out if it's a positive or negative? How do I get my 80%? Whatever. Like, yeah, it takes me 2 seconds to answer that. And then once you have that, you put your things in. And then the things that you do pick up are when there's major changes, right? Like if CMS has determined that this year there's a major code change and you're going to start getting reimbursed much better for like this particular code set, that entire code set is going to come up and you're going to be like, I'm going to raise those. If you have a major insurance change in terms of what they're paying, then you're going to run this and be like, oh, they've been paying us better for like 6 months, and now I'm bumping close to that 20%. Like now it's only like a 5% buffer. I'm going to increase this by another 15% to get that, so I'm back there. So if they give me more money again this following year, I'm in there. So it gives you a great baseline, and then it future protects you as well, right? Because now all of a sudden, instead of looking at it as a, like, I'm setting things, it's, oh, I did this, and normally I have a few items, and this time I have way more items. Is there anything in there that's a pattern that I can say like, oh, they started reimbursing better for this, or oh, like CMS says I should be getting reimbursed better for this, and insurance hasn't caught up yet. Is that something that when I'm negotiating, I can bring that to the table, right? So any questions on either of the two styles of reports? We're good there? Okay, how much time we got? Oh, good, 1:33, so we still have some time. Okay, so upkeep. And again, this is my recommend, or actually I shouldn't say that because I said PCC recommends, so I must have checked with other people. So yeah, so PCC recommends updating your prices once a year. I recommend running each of these once and doing it twice. Another way that you can keep on top of your pricing is if you use like fee schedules in PCC. So this is something where the upkeep on this is much more time consuming than what we talked about here. So you get your contracted rates from insurance, right? Where they tell you exactly what they're gonna pay you for every service. There is a way to get those into PCC. It has to be like a very simple spreadsheet where it's like, not even description, just CPT code, like price, payment, whatever. I think start date, payment. It's like only 4 columns, and that'll get you in there as a base. But if you want to do upkeep for it and have a historical record of like what was there, if they make changes, you have to go into the actual file as if you were going into like procedure codes and be like, there's a new start date for this price, it's now this date, and the price has changed by this much. And so for a lot of people, just that amount of upkeep makes it very difficult for them decide that they want to do it. But the people that are really like firm believers in having their negotiated rates in there, there's definite advantages, right? Because in the reporting, we have what are known as like over and underpaid reports by allowable schedule. And so what those will do is those will do the fine detail thing. Those will show you every single patient where you either made more than what your schedule said or made less than what your schedule said. So if you're gonna fight over every penny that, because when you have something that comes back, right, and it says, oh, this is a code 45 and we say you should be making this much money, right? Like, how do you know that that's your negotiated rate? Unless you have a chart of what your actual negotiated rate is, right? And so this is the report where, you know, where you see that right away. Or when you're going to like post. So auto post will also show if it deviated from this. When you go into the manual report, either from PIP or the EHR tool, if you have a negotiated rate, it shows up on there so you can see if there's a change there right when you're entering stuff. So you can, you know, fight right away over those things. So there are definite like huge advantages to having those. But again, the upkeep on those can be difficult once you've preloaded your original schedules in there. And I mean, I've talked to many people at this conference where it's like, even getting your hands on like a physical copy of your fee schedule seems to be becoming more and more impossible, where it's like, and then you're like, oh, I'll call my rep. Who is my rep? How do I find out who my rep is? Does anybody around me know who the regional rep for this insurance in my state is? Please help me. Like, so there's that as well that can complicate keeping you know, up on these things. Okay, so this is the opposite of what I talked about with you. So overcoming fear. So many practices worry about raising prices, and especially how it will affect self-pay. So remember that you can set your practice up with a self-pay discount, right? So does anybody here not have a self-pay discount? You do not?
Well, we do, but we just do it manually.
You do it manual. So you have one that, so thank you. Let me rephrase that. Does anybody here have a self-pay discount that PCC hasn't set for them to automatically discount at time of service? Okay. Does anybody that just raised their hand want to have PCC help them out with that so that they're not doing it manually?
Some works.
Okay. Because I know some people do like having control over what they're doing.
But if you do it, it looks like you do it based on a CPT code.
Yep.
Not necessarily across the board.
So you can do it both ways. That's what these two slides indicate. So it is by CPT code, but literally, like, when you get into this configuration file, if you don't want to do it, like, just call me or call PCC. Like, it takes 2 seconds. So you'll see here, so see how this says dat config IC underscore self-pay. Okay, I'm gonna, for the people that are on video, I'm gonna be talking very loud now because there's jets. So when you go into the insurance table in however you get there, if you go into TED through practice management, if you go into configuration in the EHR, both of those have access to the insurance table now. So when you go in there, there's a section that says special information file. If you click on there, it will bring you into what we're seeing here, where you can do discounts. Yep.
And to do this, do you have to bill before the patient leaves to be able to use the automatic discount?
Yes.
Okay, so that's the only reason we don't do it for like a teenager that has depression screens, things like that, where we haven't necessarily hit with them because we don't use status. And so that's why we don't do it. So that, but you have to do it before.
Yeah. Well, I mean, yeah, it's called a time of service discount, so you should be doing it beforehand. Also, you know, rule of thumb is if something isn't going to insurance, you shouldn't let somebody just like walk out of the office. Yeah. Yeah. But yeah, as long as somebody knows that they owe you money, like that's the important thing. Oh, actually, and for the people that were in the chat, the question was, what, you got it? You got it? Okay, okay, okay. My other classes, they're like, repeat yourself, repeat yourself.
If you can,
Yeah. Well, thank you, Douglas, for repeating it for me. So when you get in here, and again, this is what most typical PCC clients do, is they will have a different schedule, right? So each procedure code, there's like Schedule A, which is your regular price, and then if it's like, say, a vaccine, maybe like Schedule D is your Medicaid to set it to 0 or set it to a penny, and maybe Schedule C is your self-pay, or Schedule F, or whatever order you have it in. So a lot of practices will go in there and say, okay, my base price or the base price I'm expecting to collect for self-pay, so what we're gonna say you owe is going to be, this much money. So if you have a $240 charge and you're going to expect to collect $180, you would put in what you expect to collect, and then it'll do the math of what the discount is, right? I'm discounting it this percent to bring it down to 180. That's what most practices will do if they want that level of control over it. What you can also do, and again, we talked about that, is you can set your write-off amount. So this top part, it says adjust to Schedule C. So it's adjusting the price that they owe from the charge amount to what Schedule C says, so their discount is minus the difference between Schedule A and Schedule C, right? And then in terms of like a percentage discount, it's adjust write-off amount, and then over here there's a percentage. So on here it says 20. And when you're in this program, this top part is the template. So you can hit a button to select all procedures, and then there's a copy marks to temp button, which is copy any marked CPT code to have the exact same thing in it as the template at the very top. That's what that represents. So if you were to call up PCC and say, hey, I don't want to fiddle around in here because it's in practice management, I don't want to screw anything up. You could literally just be like, hey, can you go in and set self-pay to a 20% discount? And we'd come in here and literally, hit star, look for adjust write-off amount 2, then over here write in 20, select all, copy template, save, and we're done. So it's literally like a 30-second job for us to fix that if you want to do it by a percentage. Yes, Jeremy from PCC.
Also hit that and actually say, please do that. Please just reach out to us instead of fiddling with this tool, because we can also often do it in a way that's much faster and doesn't have to use the program and more efficient. And also sometimes this program, if we do it in that way, will then wipe out all that hard work, because then it goes and updates every single procedure. So actually, I would ask that you just reach out to us for this kind of thing.
So Jeremy is saying, please reach out to PCC and ask us to do this, and never look at it or touch it yourself. But again, I know there's a lot of people in this room that have probably been using this for 20 years, and they're like, yeah, I know how to do this. It takes me 2 seconds. But yeah.
We're gonna have to fix what we really miss it.
Yeah. Yes. And also you might find that if PCC does it, you try and come in here and it says, this file is now too complicated for you to access it, and so you have to call PCC. So you may see that as well. Because like Jeremy said, we can go in and be like, I know how to write computer code. I'm just going to do it by hand from Unix instead of from inside the program.
One other
It's just text. It's just text
One
files.
other thing, too, a lot of practices do like sliding fees for self-pay too, and we can also accommodate that and figure that out. So just kind of have an idea of how your practice works, how you do your self-pay, send it over to one of us. We can figure out how to make it work in the system for you.
So Jeremy just said, I'm a genius and I'll figure out all of your self-pay, in case somebody couldn't hear him. He mentioned sliding fees, and he'll work some magic because it's just an easy file. I saw a question.
Yeah, so I assume to do this, you have to have the patient set up as a self-pay insurance
Yes, yes. So the way that this works is every system should have a fake insurance that's called self-pay. Like most systems will have multiple non-real insurances. Like they'll have a self-pay, they'll have a newborn, just to do that. But yes, if you just have someone that has no insurance at all, and you get to the finalization screen, it won't give any discount. You have to assign them the insurance of I am a self-pay patient, and then it will give them that discount. Because technically, even though you can't see it, then every system has a insurance of personal, which is like, you know, in computer terms, there's like a zeroth entry in tables that's usually invisible to end users. And so personal is the zeroth entry. So even if you never give them insurance, technically the database already has them assign something as soon as it creates a account. And so you would want to change it from that no insurance zeroth entry to whatever your actual self-pay insurance is in the system. Great, I love questions.
You're at like 12 minutes.
Great. I think I might even be almost out of slides. Yeah, I am out of slides.